This conference will now be recorded. This
You might
conference
have,
will now be recorded.
there you go.
Okay. AnCan is grateful to our sponsors for making the recordings possible. They include Bayer, Foundation Medicine, Janssen, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics.
And Foundation
AnCan,
Medicine.
I'm sorry?
And Foundation Medicine.
I did say that.
Did you?
Yeah, I got
Okay.
it. Right. AnCan notes that it does not accept sponsored promotions. Any drugs, protocols, or devices recommended in our discussions are based on our peer experiences and solely on the clinical evidence that we see by reviewing the literature. Please consult your medical providers for personal medical care, and we encourage you to discuss anything you hear here in these sessions with your own medical team. So, as I said, we like to go through a questionnaire. It helps us organize the information that we then
Mark,
share. Yes.
can we say what group it is, please?
Oh, let's see. Is it Prostate Care Foundation or
No,
PCRI or
no,
this?
no. Just try the low intermediate group on
Okay.
the
This is
9th of
AnCan's
June.
low intermediate. And I'd like to lobby to get newly diagnosed thrown in the name as well. But anyway,
Yes.
okay. George, we're going to start with you. And can you tell us how old you are?
70.
Okay. And where do you live? It's Chicago.
In Chicago, yes, in the city.
And how did you first get diagnosed, and when was that?
I was diagnosed about 4 weeks ago. So this is very fresh.
And what got you to the doc and got the testing done?
Well, my PSA had always hovered around 1.5, and it appears that from the fall of 23 to the fall of 24, it went up to 3. So I was concerned about the velocity. My PCP said, okay, we'll retest it. And in 3 months, we retested it and it went up to almost 4. So she said, well, we'll do another test. But I was not happy about that. So I went to a urologist who I had seen before. And he ordered an MRI, another PSA, and a health index at the same time. Interestingly, the PSA came with a 2 number. So it went from 1.5 historically to 3 to almost 4 and down to 2. The index was around 22, and my understanding is that that is a fairly okay number. But then we did an MRI, and the MRI detected a PIRADS 4. Then we did a biopsy, and I was diagnosed with intraductal carcinoma in one of the cores. I sent the slides to Epstein, and he corroborated that diagnosis.
Okay.
That all makes sense.
Did you have a Gleason score as well?
My understanding is, and I could be wrong, that for intraductal, they do not assign a Gleason score, which perplexes me, frankly. But I do not. I do not have a Gleason score.
Okay. So it is interesting that you can have what appears to be intraductal and not show the adenocarcinoma that'll be graded outside the that area. Did Epstein have any other comments on this?
I am going to have a conference with him probably tomorrow. but I am going to have PSMA on Thursday here in Chicago at Northwestern. A PSMA PET. That all has been ordered and arranged. So we'll see what that says.
Okay, I think that it sounds like you're on a good path there. There's certainly some disagreement on how to, or controversy on how to approach intraductal disease when we don't have another area of prostate cancer to address.
Forgive me, I actually went to a radiologist and he suggested that if we were to radiate, that I could not have surgery. That's another issue that perplexes me. So in other words, he was willing to radiate. He said that it would not be effective for intraductal.
So here's my understanding on this. The older studies used older technology, and traditionally it was said that people with intraductal, that disease was not as responsive to radiation. And it may very well be that because they didn't do PET scans or the MRIs weren't as good, that the disease was underdiagnosed and was more aggressive. Because with intraductal, there's a greater tendency to find that disease has spread. Now, because of that historical basis to say that people don't do as well with radiation, there's been a tendency to suggest surgery first. And doing radiation first does result in more scarring that can make the surgery more difficult, although an experienced surgeon can do surgery after radiation. In this case, it might, you are young enough that they might say, yeah, we'll go ahead. But I don't know that we have the full answer on that yet. But traditionally, it's been said that radiation shouldn't be the first line for that. Intraductal is when the lesion is inside the glands, and it's the lining of the gland as opposed to spreading out. I don't know what else on Rick, how you would describe it.
It's in the ducts within the gland as opposed to in the gland itself. And it can get carried out of the ducts when liquid and fluids flow through those ducts. It is correct, and I learned this. We learned this. I don't think Dr. John knew it either, but we learned that it doesn't get it's not allocated a Gleason score. We also learned, and I can't remember, it was in something I read when we met George a couple of weeks ago in the active surveillance group, that I think it was Epstein or Zhao, it might have been Zhao, who said he's never seen intraductal that's not accompanied by adenocarcinoma when the prostate is removed. So it's likely that there's adenocarcinoma somewhere, but right now it's not showing up on the MRI, and so they don't have a target to biopsy, and so we don't really know.
No, it did show up. He had a Gleason 4, a PIRADS 4 on the MRI.
So right. Well, that was the IDC. What showed up was the intraductal, right. But what's not showed up is the adenocarcinoma. We don't know where the adenocarcinoma is. We know where the intraductal is.
Okay.
And the other thing we know, which is why George is here and not in the AS group, is he's got to have treatment. And the question really is, does he have to have surgery? And so we've suggested he makes some appointments, which he's done at University of Chicago, to speak with Egner and possibly Shmulewitz and Liao, and see what they suggest in terms of his treatment options.
Another thing that I would suggest asking is about running genetic screening. Normally, you would not do the somatic testing early, but intraductal tends to be associated with an increased likelihood of some of the various genetic mutations. So I would ask them what they would think about at this stage doing both germline screening and somatic screening from the biopsied tissue.
Well,
That might be
I did send out for the promise test.
Right.
okay.
So that's the germline, and I think we mentioned this to you in something I think that I wrote to you, is that you need the germline and you need the somatic,
Yes.
because what Mark was saying, just to elaborate a little bit, is that IDC, intraductal IDC-P, is associated with the tumor suppressor genes, the
TP53 loss.
TP53, P10, RB1, BRCA. It is associated with them, so we think it would make sense if they ran it, and somebody like Shmulewitz or Egner is going to get that. Well, they'll get it at Northwestern, but I think if you mentioned that to Shmulewitz or Egner, that they would be sympathetic to that.
Who should I see first?
Oh, that's a good question. Dr. John, who would you see first?
Oh, whoever gives the first appointment. The PET scan is going to be soon, and that's going to be great information. It'll take a few, it may take a few weeks to have the somatic testing. It would be nice if you could not do the prostatectomy until we have enough information to decide if you really should have it or not. We do want to get things rolling early this summer.
Is there urgency here? I mean, is this going to sort of explode readily? Do I have time?
It's very difficult to answer a question like that because of the unpredictability of these tumors and because of the rarity of your particular intraductal without any adenocarcinoma evidence. So it's hard to say exactly, but I guess my instinct would be to say that you're not dying now, you're okay now, it's not an emergency, but we don't want to waste very many weeks on this. I don't know how my colleagues feel about that kind of advice, but as long as things are rolling along readily in the next few weeks, I think that would be okay. But be sure to ask that question of the experts when you see them.
Thank you.
Yes,
Dr.
now may not be the time to go to Europe for a 3-month holiday and put this on the back burner.
That's just what I mean. Yeah.
Indeed.
Yeah,
Mark
yeah.
and Rick, is this the same gentleman that's been kicking
Yes.
around in our discussions? Oh, okay.
Yes.
Hi, I'm
This is-
John. Very nice to meet you.
Hi,
Sorry,
John. Pleasure meeting
I
you.
was late coming in.
Yeah. I mean, it's been for us as moderators, it's been very illustrative for Dr. John and for Dr. Mark and for us laymen and for Ben. As I said to you, Ben is a great mentor because he's very knowledgeable. He makes sure people understand what he's saying, and he had introductal and he had surgery, but he was also a bit younger than you, not a lot, but a little bit. and his
Nor,
disease
nor did
did
he get cured by surgery, right?
he did not. No,
He did not.
no, no. So he, if I remember, I could go look, but I think he got about a year and a half out of the surgery, and then his PSA started to rise, and he's been on treatment ever since. So I think he's worth listening to.
I've been talking to him, and yes, he's great, and I truly
Yeah.
appreciate his comments, and I thank you. Yeah, my objective is really to preserve my life and to avoid surgery or delay surgery if at all possible. You know,
Mhm.
if I can get another 10 years of life, I'll be happy, frankly.
Mhm. I just don't know enough. I can't tell you because I just don't know enough. That's why I really want to get you to the docs that we know are really good at with this stuff. And I would say that if you see Egner and you see Shmulowitz, I don't know Dr. Liao very well. He has a great reputation. But certainly with Shmulowitz and Egner, you have really good people, and they won't lead you wrong. And if the decision comes out, we really think you should have the surgery, I would stand by that. I would stand by their decision. If Dr. Liao thinks he has another good option with radiation, um, you can try it. But one of the things that you cannot do is you can't just stand by. You're gonna have to have some treatment or the other, and that's what hopefully you'll take away from us here at AnCan.
Yes, and definitely yes.
Does
Just a
any,
point of small clarification, and I think I already know the answer. But when you said a radiologist advised you about not using radiology, did you mean a radiation oncologist, or did you actually talk to a radiologist?
A radiation oncologist at
Oh, thank you.
Northwestern,
Okay.
yes.
Yeah, very good. Just making sure.
Yeah, it was a
Thank you.
radiation oncologist at Northwestern. I don't know him, but I don't think that was great advice because there's so many other alternatives today, and it's very old advice, as Dr. Mark will attest.
again, I think the problem is there's a lack of new advice with all the new tools we have. So
Yeah.
we really don't know what we're doing. And then it's going to be, it'd be great if there were a clinical trial now to say, with this new information and new tools, we can do a better job and it's reasonable to revisit. Um, but the old school is to go ahead and do surgery in this case
Yes.
and not to look towards
Yeah.
radiation.
Well, I'm pulling away from Northwestern. I'm pulling away from Northwestern. How do you guys feel about HealthFand?
He's really good. We like him a lot at AnCan. He's very proactive in terms of active surveillance, which is great. Um, but I'm not a huge fan of North Shore, and I don't think you get all of the same additional amenities. I mean, for example, there is no medical oncologist there. He could send you to a GU onc, but the GU med oncs aren't particularly well known to us at North Shore. And if you had 3+3 and the doctor was saying to you, "Oh, you got to get surgery," we'd say, "Go see Healthfund." And I'm sure he's quite knowledgeable on these more complicated cases, but he doesn't have in our view, he doesn't have the backup that, say, University of Chicago or Northwestern have. Is that a fair enough answer?
Yes, it is. It is. Thank you.
So I just want to say to the group, this is not something we hear very often, as I'm sure you recognize. We don't talk about intraductal very often because it's really rare. I mean, not totally rare because we have other people with it, as you've heard, but it's really rare. So does anybody in the group, this is an opportunity, if anybody has any questions about intraductal, put your hand up.
Or any comments?
Or any comments or any questions for George?
Marty, go ahead.
Yeah, so I thought I saw something in my biopsy report that said something about intraductal, but the final report that I got didn't mention intraductal, but it did mention cribriform. So
Okay, we'll go over
I
that
don't know
when we
if there's
get
a
your call.
connection. I don't know if there's a connection between those two.
That's a really good question, and we'll, just like Dr. Mark says, we'll cover that with you in momentarily. Is there a connection between intraductal and cribriform? I think there is. This is my understanding, because the intraductal is more reference to the location of where it's found. But then you look at the type of cancer, the physical qualities of the cancer cells, and I believe intraductal can also be cribriform. Am I right, Dr. Mark, or am I wrong?
I'm really not sure about them. I know that I've seen them reported together, but I don't know if it's the same area that demonstrates both. I
They
think one
look
of
kind of
the
similar under the microscope. Especially large cribriform looks a little like intraductal, but
Okay.
I think, I don't know, I would love to know this, whether the actual origin cell is different. Whether it's a ductal cell or a gland cell that sparks the
Oh, you see, that's why he went to med school and I didn't.
But you know, all I'm doing is raising a question. I would love to know.
So, yeah, my understanding is with the adenocarcinoma, the lining of the glands would normally be one cell thick, and with the adeno, the walls of the gland are thicker, and with the intraductal, it's just a chunk of tissue free floating inside the gland, and you may not see the thickened wall. I think the thing that's going to be interesting, that this will be one of those areas, despite what Dr. Epstein has talked about, the artificial intelligence. I think the ability of the artificial intelligence to look and categorize a cell and define it by the neighborhood that you find that particular cell in is going to be very helpful. And I think when he talks about artificial intelligence is really not accurate, I think we have to remember that not every doc is Dr. Epstein or Dr. Zhao. And some of those people might well be helped. Some of the other people might well be helped by having artificial intelligence look at this, and they may be able to better characterize intraductal and cribriform.
I have to say that this is very new to me. The last 4 weeks have been a ton of bricks, and I'm very thankful to AnCan and Rick and for the help that I've received. But this is very new to me, frankly, and so we'll move forward.
Well, we hope that you'll come back and share what you hear and learn from the other docs. That'll be helpful.
I sure will.
Okay, if there's nothing, did someone else have something?
It's me. Would you like to meet my therapy dog?
Oh,
Come here, you big monster.
Where did this come from?
he's shy.
Yeah.
He's shy. Come here.
Whose dog is that, Dr.
This
John?
is my daughter's boyfriend's
Oh.
dog.
Oh.
Weighs 160 pounds.
Oh my gosh!
Oh,
What sort
yeah.
of dog? What type of dog?
He's a German Shepherd.
What type of dog?
He's a German Shepherd. Daniff, which is half Great Dane and half Italian Mastiff.
Oh, jeez.
Oh my God.
Wonderful. As wonderful as long as the dog doesn't insist on sleeping in bed with you. Okay. Let's move on, Marty. You are up now. So let's start by how old are you?
I'm 72. I'll be 72 June 16th.
Okay, happy birthday. Where do you live?
I live in Odenton, Maryland, which is right outside the gate of Fort Meade, where the National Security Agency is located.
Yep, I used to live in Columbia, and my sister worked over there at Fort Meade. When were you diagnosed, and what got you to the doctor being able to diagnose?
So my paperwork that I went back to look at when I did the biopsy was when I was determined to have the cancer was dated March the 5th. But I think that it took them about 3 or 4 days to actually get the results back to me. So it might have been more like the 9th of March. That was when I was.
What got you to the doc to get tested, or what was this?
Well, I was going through an annual physical, and I just happened to ask the doctor about taking a PSA test because I hadn't been taking PSA tests routinely, and I had one doctor that told me, well, why do you want a PSA test? And that was when I was 69. So he kind of told me not to. A year later, I said, well, maybe I better take a PSA test. And when I took the PSA test, it was 6.9 or something like that. Okay. So it was outside the normal range. And then we decided to do another one. And the next one came back, I think, as an 8. And then we took another one. And the next one that I took came back down to 7. And at that point, the doctor decided I needed to be referred to urology. And the urology folks gave me a, the normal, let me check your prostate, bend over, right? So that was the first step. And they didn't see anything suspicious, but then they said, we're going to have to follow up with an MRI. So then I took the MRI. This all happened in the space of about 3 or 4 months, I think. And so I took the MRI. The results came back as, evidence of cancer in a couple of areas. And then I was then told I needed to do a biopsy. So the biopsy was, I'm sure all of you probably know about this, that the doctor will look at the areas where they saw the indication of cancer, and then when he goes in, he makes sure that what he sees and what was in the MRI report lines up, and then he starts taking the samples. He has to do some sort of correlation, right?
So do you know if a lot of times what will happen is the two images are actually combined and lay over. That would be called an MRI fusion biopsy.
Right.
And then the other is a cognitive biopsy where, let me look at the MRI and I think I'm going to stick the needle here based on what I saw in the biopsy. Do you know if it was that?
Yeah, I'm pretty certain based on the conversation that was going on in the room when I was doing the biopsy that it was the fusion type, because they spent a lot of time making sure before they started that images were lining up and that they were hitting the right places.
And was it transrectal or transperineally done?
Transrectal.
Okay. And what Gleason score did they provide?
Okay, my paperwork says my Gleason score was a 3 + 4, 7.
Mm-hmm.
And that was in one of the 3 cores the 3 out of the 14 cores that were positive. And the
Okay.
other 2 cores were 3+3. So I got a 3+4, which is a 7 Gleason score, according to the paperwork.
And do you know what percent 4 it was?
On the 4, I think I'm looking at this. It says it's giving me 2 percentages, and I think maybe the 3 was 10% and the 4 was 15%.
Okay, so one would be the percentage, you have this strip of tissue, and one would be the percentage of the strip that is cancer, and then the other would tend to be the percentage that's a 4. But in either case, 10 to 15% is below a threshold that we would normally see. Did you get a second opinion on the pathology from either Dr. Zhao or Dr. Epstein or elsewhere?
No, I've been working primarily with my urologist, Dr. Chestnut at Walter Reed.
Okay, so that might be the first thing that we tell you is to send the tissue off to get another opinion, because frequently up to 25% of the time when it's read by one of those 2 people who are the foremost prostate pathologists, they're going to change the diagnosis such that a change in plan will be carried out. So that's important. Do you know if they did a DECIPHER score?
No, I'm not aware of that. No.
Okay, so that would be another thing, is to get a DECIPHER score to look at the tissue. It may help predict the aggressiveness. So those 2 things, I think, before even talking about treatment, would be to do the DECIPHER score and get a second opinion from Dr. Ming Zhao or Dr. Jonathan Epstein. What did your urologist tell you about how this ought to be addressed?
Well, Walter Reed does a seminar, and we meet with a bunch of other patients that have been recently diagnosed with prostate cancer, and they give us a sort of a one over the world education together with the findings of each individual. And so I'm actually reading the diagnosis summary that was presented to me, right? That's so I know how many cores and how many were positive. Right. So as a part of that process, we get to talk to a radiologist, and then Dr. Chestnut, who is the surgeon, will also talk about the prostatectomy. So the only options that we have been talking about is either radiation or a future prostatectomy. And along with that, because I have a very large prostate, I'm supposed to also go through a therapy to reduce the size of the prostate, which currently they're talking about ADT. So I have lots of questions because there's risks associated with doing ADT because I am a heart patient. And so.
Okay, so let me make some comments and then we'll throw it out to the floor.
Okay.
But first, I think 72 is too old for surgery. Used to be 70. And then as active surveillance got more active, surgeons had fewer cases, and people, that limit of 70, below 70 for surgery got pushed up. When you look at any kind of treatment, you have to figure out, is this person going to be around for more than 15 years? If you're 80 years old, I wouldn't think about surgery or perhaps treatment at all, because the likelihood that we're going to make it to 95 doesn't warrant going through what surgery has to offer. I am a retired surgeon, and at 72, I would not tell someone to be in the position you have to be in the surgery for 3 hours or longer, particularly with a history of heart disease. Now, the GnRH agonist part of the ADT is associated with some increased risks, but Orgovyx, which is a GnRH antagonist, seems to have reduced that risk of heart disease. But no matter what we do, we have to remember that we're sitting here talking about our prostate cancers when if what we want to do is be alive, we have to talk about our hearts and our cholesterol and our exercise, because each of us is more likely, in this group, is more likely to die of cardiovascular disease than from prostate. But it doesn't mean we don't have to make the right decisions and learn about them. But I think from the standpoint of treatment, at age 72, modern radiation might be a better approach. But what you have said so far, we do not have enough information to suggest. I wouldn't have enough information to even look at treatments at this point. From what you've said so far, you'd be a great candidate for active surveillance. But without the second opinion read and the DECIPHER, I don't think that's the case. Now, Rick has posted in the chat window, if you look up to the upper right-hand corner, you see something that looks like it might be a person, and it says 23, and next to that is the chat window, which is 2 square boxes. And we have in there the information for contacting Dr. Zhao, who's at Mount Sinai in New York, to arrange for a second opinion on the biopsies. And that's, we talked before to George about time is of the essence, or at least don't play around with this. In your situation, this is not a risk. You've got time, and I'd work on getting those answers. So
just a question. So we're talking about people out of state. Is there no one locally in this area that you
not
would
to read the
recommend?
pathology. It really doesn't matter. You don't see the pathologist. They have either they're going to send them already cut slides or paraffin blocks, and they will read this and get on the phone with you. So it's not an issue of where they are, unless your insurance only covers doctors in the state. But even so, it's not that expensive. But to go through a surgery that you probably don't need, at least from what you've told me here, would be a big mistake. You want to get it right. The problem with prostate cancer is not so much the live or die. In your situation, the PROTECT study out of England said kind of doesn't matter. In that study, some did radiation, some did surgery, some did active surveillance, and they all did about the same. What we're really concerned about is what can we do to manage this, to stay on top of it, and not make our life miserable. And that's kind of where you are, is do no harm.
Well, I appreciate what you're saying. Obviously, I am trying to get the best information I can. I think I went into this because my family initially said, "Oh, this is easy, just get it cut out," right? And when I went into the discussion on the seminar, it became clear to me that that wasn't so easy. So this is important for me to understand what steps to take, right? And I have talked to my cardiologist about, doing the ADT stuff and the impact on the heart. And there are other procedures for reducing the size of the prostate. But you are the first person that I've heard that recommended at my age not to have surgery. And I didn't hear that from the surgeon. He didn't say no, although I did have a strong sell by the radiologist. So,
Well, I think that's probably why. In one of the groups that I'm in online, there was a 58-year-old guy with a Gleason 6 who was talked into doing um, a prostatectomy. He was 58 and a marathon runner and had a pulmonary embolus and died 12 days after. 58 years old. I mean, and the other issue is the potential. Why it's not everybody, but there is the potential that you do surgery and you're wearing diapers for the rest of your life and you can't get an erection. That tends not to happen with radiation. Erectile dysfunction can be an issue, but the real issue is you may not need any treatment. And regardless of whether you do surgery or radiation, there's a risk of recurrence. Right now, the most recent data that I saw was 10 years, 95% not having issues with recurrence, 10 years with the MR focused ultrasound. So I really think that you need to figure out, do you really need treatment? And without the right information, you can't say that. The risk of the ADT, no one feels good, no one loves ADT, but now that we have Orgovex, worst case scenario is you can't stop it. If you've gotten the pill, you can just stop taking the pill and it comes back sooner and you should do well. Let's go to Rick now and see what comments you have, then Bill, then John. Rick, I can't hear you. Your mic is on, but
You can hear me now.
Yes.
It's playing games. Goku plays games with my default. So I'll segue right into the ADT. You will not need to do very much ADT, maybe 3 or 4 months. So most impact from ADT takes quite a long time, at least nine months or more. So I would be talking to your cardiologist to ask him about the impact based on the length of time you're going to be taking it. Because, you know, if you're somebody like me or Dr. John, who had to take it for a very long period of time, the risks are very different. Dr. John happens to know quite a bit about the cardio risks. I'd also, if you're concerned, try and find a cardio oncologist. You're not going to find one at Walter Reed, but you probably will find one at Hopkins, maybe even at Sibley. And these are all really, really important. We're not big fans of Walter Reed for a whole bunch of reasons. They're a bit of a one-track pony, or maybe a two-track pony, because they like to intervene. I cannot remember finding a man coming out of Walter Reed who was recommended to do active surveillance. I'm sure there's a few, but very, very few. If you've got a 3+4, however much 4, they got you on the operating table or under radiation therapy. And that's not how it should be. Dr. Chestnut's very fond of his knife. I'm sure he's a very good surgeon. I don't think he gives very good advice based on the number of men who have come to us coming out of Walter Reed. Secondly, I'm not surprised. I'm guessing that you've been at Walter Reed for a while, and they were the people that didn't give you a PSA test. They didn't give a lot of people a PSA test, as we well know at this point in time. And, you know, they're not big on PSA testing. I don't know why. I think it's a big mistake, but it results in situations like yours. But yours is very, very recoverable. And if if the 4 is very limited and just in that one core, you are a good candidate for active surveillance. And you'll find a lot of guys in the active surveillance group who have similar situations, maybe even slightly worse, that are doing active surveillance. So if you feel like you've got the head to do it, you don't need to get it out. I mean, this got to get it out is not a good attitude. I would agree with Dr. Mark on surgery for a man of 72. Probably not the best option. You don't want to be upside down for 5 or 6 hours. It's not a great option. The last thing I would say about your biopsies is that you're going to get pushback from Walter Reed. They're going to say, well, what do you need that for? We've got good pathologists. No, you must get those slides reread, but preferably by either Zhao or Epstein, either one. But don't let them push you into not doing it, because we want, they don't have a great track record based on what we've seen. This is based on what we've seen. So definitely get those reread. Come back here. I'm not sure that the VA treatment isn't better. I mean, hopefully you're dual enrolled anyway. It's smart to be, if Jim's shaking his head, but if you're not dual enrolled, get your ass over to the VA and get dual enrolled. Really, that's also really important. I'm figuring you probably have TRICARE, do you not?
Correct.
So, you know, you can go for surgery. You can go up to Hopkins. They're really good. And that's where I would be going. We'll send you to Pavlovich, who will favor active surveillance if there's half a chance. And there are other doctors like Pavlovich there, but we like Pavlovich. He knows who we are. So those are my 2 cents.
Okay, Bill in Virginia, you're up.
All right. Well, Marty, I'm going to give you just maybe a little bit different perspective. I am a patient of Dr. Chestnut's the last 2 years. I'm 3+4. Similar scores to you. I'm 61, so I'm a little bit younger. I will say that I did not feel like I had all the information I really wanted based on the seminar. It was very helpful, and it gave some links to the support groups, and that was helpful to hearing a lot of other stories. So, you know, I don't know if I told Dr. Chestnut, I got a PIRADS 4 first look on my MRI, and then the next one was 5. And so he took a lot of cores because he was a little concerned. And I said, I think I'm going to stick with active surveillance. And he supported that. Happy to share any other things with you, but not to take up too much time.
I appreciate. Wow, this has been awesome. I got more out of this group than other sessions. So thank you.
Well, we've all been dealing with it for years. If you add up all the years of prostate cancer in this group, it's more than a lifetime. Let's see, John, Dr. John, you're up.
It should reassure you to know that your navigators are in perfect agreement with each other. Rick has already made every single point that I was going to make. I do think that in the unusual event that you get put on ADT for any prolonged length of time, that it would be a good idea to see a cardio-oncologist. And I was also hoping to be the second person to be skeptical about you having surgery, but Rick already got that place, so I'll be the third. That's all I have to say. And thank you, Rick, for making all those points already.
John, I just wanted to briefly ask you a question because I was interrupted by doing this. with a pop-up on my phone. Is Ali Antonucci a relative of yours?
Yes. What did she do? Text you?
She contacted me through LinkedIn,
Come here.
and
This is
oh,
my daughter. This is my daughter, Allie. She came
uh,
in and watched me in group and said, "Who's that guy?" So I said who you
you
were.
just popped. Now that's, it's like
That's
when you say
strange.
something on Facebook, you get an
Oh
ad
yeah.
for it. But this wasn't Facebook. I didn't even say your last name. And immediately when I said Dr. John, Allie popped up on my LinkedIn on
So
my
much
phone.
for privacy. And I actually wanted Rick to meet Allie. She might be sitting. Oh, you have met already? Oh, she might be. She might pop in on high risk group tomorrow.
Oh yeah, Ali, we love to have you. We've only texted each other. We've never met. Oh yes, we did. We met. I saw you one time at your in San Diego when John was there. So I met you very quickly. Yes, and everybody should know that we're working on to get a webinar date with Ali and a doc in Southern California who Dr. Mark knows on how to deal with your payers when they give you a hard time. So all of you have had insurance turned down, and what do you do next, and where do you go? Well, that's Ali's field, and also this other gentleman, Dr. Gill, who is a medical director for one of the payers, and we're putting a date together, so that'll be a great webinar.
Okay, well, I will go ahead and look at your information that was texted me in a bit here.
Okay, we'll be
Mark?
inspecting your bank account numbers later on, Mark.
Oh, yeah, exactly. They won't have to find. They won't find much there, so it'll be okay. Jim, you're up.
Yeah.
Oh,
There was something within the discussion that Marty and I talked about, and he mentioned that they suggested that they can reduce the size of the prostate through a medical procedure. Marty, what was that called?
It's called arterial embolism.
So, what is an arterial embolism? I'm just curious because I've never heard of that
Well,
as a
I actually looked it
procedure.
up. I actually looked it up on the internet because I heard the term, but it wasn't really explained. I understand what they do is they uh, shunt the artery that provides blood to the prostate. So in that way, you reduce the size, and it's like going in to get a vasectomy. They go in and they go through a procedure. They give you a little bit of contrast. They go in there and then snip, and then they let you go home. So I don't know any more than that.
I would ask about the degree of discomfort. Well, it is a catheter that goes into the groin in the blood vessels, and they're threading this catheter up to the area of the prostate, and then they put in a like little pieces of styrofoam or a material that goes through the catheter and blocks the blood vessel. When your heart, the blood vessel blocks, and you don't have blood flowing to the heart, it's kind of a painful experience. I don't think anybody went to the ICU because they lost an artery to their prostate, but I imagine it could be kind of uncomfortable afterwards as his tissue dies. Um, but I've seen a few people who have been advised to do that. Um, if you're not doing treatment, do you know how big the prostate is? First off,
Right?
how many cc's?
I don't know what the right answer to that is. I know it's over 90.
Okay, and do you get up at night to pee?
Yeah, I do.
How many times?
Probably 3 times.
Okay. So the other thing that you ought to ask about, I mean, if you're not having significant urgency during the day or urgent continence where you have to go right away, it may not be a bad idea to think about one of the focal treatments to reduce the size. They also can use finasteride, which is a pill that will help shrink the prostate as well. But if those symptoms are kind of mild, then you might not need that treatment. If they were saying the prostate is really big, and in order to do surgery, we need a smaller prostate,
That's what they were saying.
and you're doing 2 procedures, that doesn't make sense to me because, again, I don't see a benefit, at least from what you've said, of approaching it. And if you can live getting up at night the way you're doing, I might try Flomax. I might try finasteride pills.
I've been on Flomax for a long time already.
Well, that won't shrink the gland, but it may help increase the capacity so that you can store longer at night. But the finasteride might be something that shrinks it. And there are a lot of procedures, but most of the focal treatments that are going to shrink the gland are going to require a period of time with the catheter, which isn't always fun.
Okay.
Okay. Anybody else?
Thank you.
Anybody else have any comments for Marty? Okay, we will move on. Mark, you are up next. Where do you? So I'll go through the questions and then we'll open it up to the group. Where are you? Where do you live now?
I live on Long Island outside New York City.
Where on the island?
A town called Seacliff. Anyone knows that?
Okay, I used to live in North Belmar, but I was obviously didn't get a chance to see all the island. How old are you now?
I am 63.
And how were you first diagnosed?
I was going to the same urologist for 20 years who was very laissez-faire. My PSA, like George's, was low to mid ones for 15 plus years. And then it went up to 2, and then 2.5 or 2.25. And I said something to him. He said, you should come back in 3 months and do it again. It went up a little bit more. And he said, we'll do it again in a few months. And I'm like, I switched urologist, went over some things with me, and he said, I'll give you an MRI because both my grandfathers died of prostate cancer, and so I was worried about it. So he said, I'll do it. I don't think you have it. And I had 3 lesions at that time.
About when was that done?
That was April of 23.
And do you know the PIRAD score on the lesions?
It was 3, 3, and 4 initially. They changed over time.
Okay, so what happened next?
What'd you say?
What happened next? You had this first MRI. Did you go for a biopsy after that?
Yes, I got a biopsy. He did a biopsy. It was Gleason 6. With that, I will be honest, I'd never heard of active surveillance at that point in time. I left that urologist. I went and saw 4 or 5 surgeons in Manhattan and 2 radiation oncologists. And I ended up I think all of the surgeons said they wanted to redo the biopsy again in 3 months. I ended up riding two horses for a while, a Dr. Eastham at Sloan Kettering and a Dr. Tawari at Sinai. I ended up picking Tawari to stick with. And I've had 4 biopsies, 3 MRIs, I think, a lot of other tests. And it got to the point I had 2 or 3 episodes earlier this year. Well, first off, my last MRI late last year showed one of my tumors had grown a little bit from 0.8 millimeters to 1.2 millimeters. And I was at that point, two of them were PIRADS 4 instead of just one. A little after that, they did another biopsy, still Gleason 6. Then I had some intermittent bleeding. And I pulled the plug. They sent me, Tawari sent me to an oncologist, and they said I should move forward at this point. I had surgery 2.5 weeks ago.
Okay, so a few things that I would comment on with the Gleason 6 doing surgery in this day and age, unless there's other evidence that
I will tell you, the oncologist wanted me to do it. I couldn't reach the oncologist I wanted. This one did want me to have it. Tawari said it's fine staying in active surveillance. As it turns out, it's probably a good thing I had the surgery because I had positive margins, which I know is unusual for 6. It still stayed as a 6, but I had positive margins and perineural invasion, which I don't think is a good thing either.
Okay, so
my Gleason never got high. My PSA, they took it a few days before my surgery, was a 3.
Okay, so one thing I wanted to comment on, you mentioned about the size. MRI is really pretty awful predicting the size of a lesion.
Yeah.
When you're getting gadolinium with it, not everybody does still, but with gadolinium, there are 3 different protocols that they do, the T2, DCE, and DWI. And I don't know all the details, but they're basically 3 different procedures looking at the prostate. The same lesion can vary by 50% or more in size between those different measurements. If you take it and do an MRI and then come back a week later and repeat the MRI using the same protocol, you're going to find that the size will be significant. Now, postoperatively, was your Gleason score still the same?
Yes, stayed as a 6.
Okay. And do you know if Dr. Zhao at Mount Sinai had read the biopsies?
No, he's not on the biopsy. I had asked for him, and they I guess he was away that week. And that is a question I have for you. Do I ask for him to reread it, or is that awkward doing it at the same hospital, or send it across town to, I forget his name now, but
Yeah, and Jonathan Epstein.
yeah,
I'm not sure at this point.
it matters anymore. I don't know.
I guess they probably would not do ADT or immediate radiation, and they'd probably still just follow along on the, just follow along on the PSA. And if that moves, then look at radiation. My bias.
That was the initial response. They said a lot depending on what my PSA test is in a month or another month from now or so.
Yeah. I think one of the problems with PNI, we know that it has a greater likelihood of recurring. What we don't know if there's a better approach to managing situations where there's PNI. The argument about margins, you want to stay on top of it and preferably get to treating it if your PSA gets above 0.15. That would be the time. You don't want it to get over 2. You don't want to get over 0.5. You want to treat it early on. I'm sure that Dr. Torrey will get you in a good shape there. But I'm curious about the moving to a surgery on a Gleason 6. I don't understand the rationale for that. With a relatively low PSA, unless it was a DECIPHER score that was out of line.
My DECIPHER score was good. I don't have it open in front of me, but it was in the low risk category. Everything was low risk, and yet here I am with a positive margin. So,
and that doesn't mean that those cells on the margin would not have been there or treated had you done radiation or had you done nothing. It may still have stayed in check and not progressed. So I don't know that you can say, gee, I did surgery, so now I've taken care of this. There's still no evidence that doing the surgery gets you a better outcome.
Yeah.
And not doing.
What I want to add to that, Marty, is that even though those cells were outside the gland, if they were still 3, there's no concern that they would spread or lead to prostate cancer. And that's the consensus from a number of doctors, really good pathologists. I mean, we've got guys in the AS group who have 11 out of 12, 12 out of 12 cores, all 3+3, and the docs are all saying, you're fine, just watch it. And we do not subscribe to interventional treatment for people that are only 3+3.
The other thing that's interesting with this is there have been studies looking at circulating tumor cells on patients who presented for whole gland TULSA. All the testing showed that the disease was confined to the prostate, and they looked at circulating tumor cells, and they were there. So very early, we had these cells getting into our circulation. And the nice thing is our body probably holds them in check, and those cells remain dormant. We don't know those factors that get them to reinitiate, but it seems like whether we choose radiation or choose surgery, the cells got into the circulation, they've spread around, and they remain dormant until something that happens that gets them going again, and you're not any more likely to prevent that necessarily with surgery or radiation. But the chances of a problem and this recurring are still pretty low. My other concern is that frequently docs will say, well, you're young. Young people do better with surgery. And the issue with that is, yes, if you are 63, you will do better and tolerate the surgery better than someone who's 75. But it doesn't mean that at 63, you will do better with surgery than you would with radiation. In fact, doing that approach, it may end up that for the next 30 years, you deal with incontinence and erectile dysfunction. So the old trope that you hear that young people do better with surgery, you have to ask, do better than who? They do better than the older person.
In that regard, it's too early to tell on potency or not. And there's something I'm going to add to that. The continence I had, truthfully, the day after they took the plug out of me.
Yes, can we hope that it will stay? And you're one of the lucky ones. Not everybody.
No, I know.
There are some.
I am lucky.
The other issue that they talk about for young people is they say, well, if you're radiating early, you have a longer time to get cancer afterwards as a result of the radiation. And it turns out that with the newer SBRT, and now even looking at MSK, I don't recall if Hermes was out of there, but there's studies looking at 2-session SBRT, and with the smaller margins with newer radiation, they really don't think that the risk of cancer, secondary cancer, is going to be greatly increased. Having used
a couple things. I have other health issues.
Yeah.
One of them is a primary immune deficiency that gives me I think it's a 40 times higher chance of lymphoma. That gave them a little pause with radiation, just.
Yep. I can understand that.
And on the potency end, around the same time as I got prostate cancer, my testosterone started falling. And now one of the levels is at the bottom of the normal range, and one of them is 1/4 of the normal range. And no one wanted to give me testosterone while I was untreated.
Well, and certainly at this stage now, it's not going to be likely that they're going to look at that. So that could be an issue. George, you had a comment?
Yes. Why is it that they do not rate intraductal with a Gleason score?
Because it's not an adenocarcinoma. It's a different type of appearance and tumor and location. It doesn't have the same structure of glands, and the Gleason score is based on the appearance of the glands. And since that isn't glandular tissue, it's not amenable to doing a Gleason score.
I asked my urologist, and he said, well, you're a 4.
Well, the other thing is that they used to say, if you had any of those things, we're going to call it a 4 because it behaves like a 4, but it's a totally different appearance on the slide. They're just saying, well, with what we see, it's more aggressive. Let's move on here. Bruce, you wanted some time tonight.
Yeah, I just wanted a little clarification as I'm learning.
Actually, it was the other Bruce, but if it's brief, go ahead. Actually, I have you both Bruces. So go ahead, Bruce Hoffman.
You had mentioned earlier on the MRIs. I didn't catch the first two. The third one was something about in interpreting it was DWI. There was 2 ones before that you had mentioned.
DCE and DCE and T2.
Now, how would I know reading my report which one they were using?
You don't. It's not important.
Oh, it's not
The
important.
important thing is that if you're doing focal treatment, you got to know that there's a variation in size, and we really don't know by looking at the MRI exactly the size of the lesion.
Okay. And then my second question, just for clarification, is you had mentioned, and I didn't ask last time, but let's use SRBT treatment. What is that?
SBRT.
SBRT.
It's where they make a cast, like you had a cast on a broken bone for your lower half of your body that immobilizes you. And it is usually done in 5 sessions of radiation. And with the newer machines, it allows you to reduce the margin size compared to IMRT. The IMRT will be 28 to 45 sessions if it's proton, and the SBRT is 5 sessions now, and in many cases, 2 ongoing studies and 1 that's been completed, they've done it with 2 sessions, and they actually find that there are fewer side effects and potentially better response going to 2 treatments. Now, there's also a genetic basis, and the last time we were on here, we had the doctor from MiraDX speaking about Prostox, and that's a genetic test that allows them to determine whether you're at risk for late side effects by increasing the daily dose. But a lot of docs will tell you, well, the lesion is close to the ureter, or we want to take it easy here so we don't damage things by going slower. And it turns out that's just not the case. People do better with the SBRT unless they have this genetic risk for complications from it. So that test is called Prostox. Short of that, most people should be doing SBRT, and preferably either a VMAT protocol where the whole system swings around to send the beam in from multiple different angles, or CyberKnife does that, but it doesn't focus the beam as well as the other techniques. And right now, the MRI linear accelerator appears to be the most had the best collimators and focus, and is monitoring the actual lesion size on a day-to-day, and can recalculate the entire treatment plan each day as you come in, which is called adaptive radiation therapy. So I think that's the state of the art, but the old IMRT is old school and probably.
Can you repeat what that last testing or treatment was? I didn't catch the treatment.
Well, the treatment is IMRT. That would be the standard 28, 35, or 45-day radiation exposure.
And you're saying that one can identify from treatment to treatment where it needs to focus.
With an MRI linear accelerator now, they can recalculate on a daily basis if there's swelling of the gland, if the gland shrinks, if you have a gas bubble in the rectum, if your bladder is filling. As it's going on and treating you, it's looking and saying, you know, I don't like this. Do you want to change the protocol today? And it sends notice to the technician, the radiation therapist, and the radiation oncologist to say, we need to change this. Let's go on, and Bruce Shrimp. Yep.
Hello.
Hi.
Yeah, I don't know if you can see me. For some reason or another, the camera on my end isn't working, but it might be on your end.
No, we cannot see you. But we can hear you.
All right. I was at Mayo on May 22nd. They ran what do you guys call it, a PSMA?
Yes.
And they also ran a PSA, and my PSA is now down to 0.2. It had been a year and a half ago, it had been at 2.0. So the radiation oncologist was very happy about that. And then I saw, and it was a telephone conference. I saw a doctor, and I looked up his name a few minutes ago, and I, for some reason or another, I'm having trouble remembering it. But he's the guy that is going to do the ablation. There are 4 lesions, I think you would call them. It's still within the prostate. It has not spread anywhere else. It is not in the lymph nodes, not in the bones, not anywhere else. And that is scheduled for August the 1st.
What was your initial treatment and initial Gleason?
I had a full body scan. I had a paraganglioma.
Okay.
On my carotid nerves and artery. And they gave me a full body scan, and that's how they found the prostate cancer. And I was diagnosed with a Gleason 5 + 4 = 9. Well, it was, I guess my wife and I have a disagreement if it was November 30th or December 1st, but the year was 2017. And I had completed the paraganglioma treatment, and then I was brought back a month later to the Mayo Clinic, and I had, I think I had the 28 sessions of proton beam therapy and Lupron. I was on Lupron for 18 months. And my PSA went down, everything was going along well, and then it started rising again. And in, I think it was 2023, I was back at the Mayo Clinic for additional radiation, but it was the conventional radiation. And then my PSA started to go up again. And then I went back to the Mayo Clinic, and that's when they decided they want to try cryoablation.
Okay, Bruce. I think with the recurrent disease that you've had here, you might get better feedback or more on target feedback from the high-risk recurrent group, which is, I get confused as to which weeks they are.
It's tomorrow. It's
Okay.
tomorrow at 6 o'clock Eastern time, and I believe that Bruce has visited us in high risk.
Yes.
I'd be interested in knowing why they didn't talk to you about lutetium, Pluvicto, in a situation like yours.
Well, there's a number of reasons why.
Okay.
First of all, I don't think he's had a secondary. He hasn't had a secondary ARSI. The other reason is because it wasn't
Metastatic.
it wasn't approved, and there's no evidence. There's no real evidence of the metastasis.
Yeah.
So there's nothing out there. So there's a whole bunch of reasons. But why did you come to visit this group, Bruce? What is it that you want from this group? Because as you know, all of our recurrence discussion is not in this group.
Well, maybe I just got an email about it and I responded to it.
Well, certainly wish you the best and hope that that helps. But sounds like tomorrow night may be better.
Yeah. So
better
just to
information.
clarify, this is the low intermediate group, as most of the guys in here know. And if your disease recurs, then almost always you're going to be in the advanced group, which meets on the first and third Mondays and the second and fourth Tuesdays. And so that's what you got to look out for. And Dr. John's moderating tomorrow, and we can talk to you a little bit. Now, we may know a little less about the cryofocal treatment that they're suggesting. So if you've got any questions about that, ask Dr. Mark right now.
And then if you come tomorrow, I'm going to ask you if you ever got around to seeing Dr. Heath.
Oh, yeah. Well, the Mayo Clinic was not at all. How could I put this?
Well,
Friendly about seeing Dr. Heath.
Let me put it for you. You are your best advocate, Bruce. And if the Mayo Clinic wasn't friendly about you seeing Dr. Heath, as we said to you, come back to us. We'll send Dr. Heath a note. But there's a problem at the Mayo Clinic. And it's that they tend to be, and I've been wrong one time tonight, but I'm going to be more correct on the Mayo than I was on Walter Reed. They're territorial, and they don't like sending people to the genitourinary medical oncologist because they never had to do it before. But what happened is that Dr. Sartor arrived, and then on his tail, Dr. Heath arrived. They have two fantastic GU medical oncologists, and you say to them, I want to see it. You have to insist. You've got to be your own best advocate. So you call them up tomorrow morning and say, I want an appointment with Dr. Heath, and I'm insisting I have recurrent disease. And when you come on tomorrow night, you'll tell us, and if necessary, we'll drop a note to Dr. Heath, and she'll sort it.
Oh, I appreciate that. How do I contact you tomorrow night? Does the same phone number?
Just come in the Bruce tomorrow night, Bruce, and share your story. You'll do the same thing, asking who needs time, and you can tell your story then. We got a couple more people here, so I want to move on. Enrico, you're up.
Hey there. Can you hear me? Or
yes, we can.
Okay, let me just do that so you can hear better. So I finished up radiation with Dr. Nagar at MSK about 2 months ago. It was 5 full sessions. I had kind of like, the standard typical, I guess, side effects for about 2 weeks after the last session. And then pretty much since then, things have been pretty good. And it's been about 2 months right now since the last session. And 0 side effects. It's as if, if I hadn't done the radiation, I wouldn't even know, anything has changed. Absolutely nothing's changed. The next step is in a month, so basically end of June. I'm going to do a blood test and meet with Dr. Nagar and kind of see how it goes and see whether or not this treatment worked. I was expecting them to kind of say we'll do blood tests and then we'll do another PET scan and stuff like that, but they basically said no, that's not kind of how the protocol is. It's like they're only going to do another PET scan or MRI or any other further test if the PSA comes up high still. But if the PSA is basically lowering, then they're going to assume that it's working and then basically see them in 6 months from now. So that's kind of the latest update, but I'm relieved and happy that, basically no side effects to speak of.
And you did not do the RETIRE study that John and Stuart did?
Did not, no.
Okay, great.
I was not part of that, no.
Any comments for Enrico? Or questions?
Enrico, how old are you?
I'm 56.
Okay. Just curious. I wasn't able to introduce myself earlier on the call. I was having technical difficulties. My name is Jessica. I'm representing my husband on this call. So Enrico, you sounded younger. My husband is 40. So I just was curious. So thank you.
Okay. Jessica, hopefully for our next session in 2 weeks, try to get here early. We'll get you signed up and then we can get the whole history and give you some more focused information. If we have time, we'll get to that today. Stuart, you had asked for a comment. I'm not hearing you. You're not muted, but I'm not hearing you. It doesn't like your microphone. We do not hear you.
How about now?
Now we do.
Okay. Hey, Enrico, have they given you any indication as to what your 3-month expectation for PSA should be?
Not really. I mean, the conversation was that if it's obviously below 1, then all things are great. But they didn't really mention, kind of how it would progress. My understanding is that with radiation, it takes a little bit longer for the PSA to drop, unlike with surgery, for example. But I have no idea. So like I'm assuming that's kind of the conversation I'm going to have with Dr. Nagar as soon as I'm done. Have you had the 3-month follow up already?
I've had 3 and 6 months.
Okay.
How high was your PSA?
Mine went never. It was the highest I got was 5.4, and it was about 4.8 when I went into radiation. So,
based on the conversation that I had because we were talking about radiation only versus focal treatment only, what to expect, and what I was told is that it could take 6 to 12 months until you see a significant drop. So only reason for raising that is don't be disappointed if the number doesn't go down much.
okay, that's good to hear. I had heard that it could take frustratingly long for it to go down. So that's that's a good reminder. So thank you for that.
Okay.
Because so it's like the stress is now on like this. I feel like it's Russian roulette now on the blood work. So every time. So it's just I gotta take a deep breath and just let the process play out.
And also be aware that you can have bounces where it will go up one time. If it goes up 2 or 3 times, that may be significant. If it's down and then up, but the general trend is downward, that's great. The problem that we have is that we hang on each of those numbers, expecting it to tell the whole story, and a single number doesn't tell the whole story. It's really where we are 2 years down the road. If it keeps on trending downward, we're great. And I think we just need to remember that prostate cancer cells don't die until they try to reproduce. With the radiation, you get single strand and double stranded breaks. Single strand, some of them can be repaired, some may not. The double strand breaks, those cells are destined to self-destruct when they try to do something. But if they're sitting there dormant and not trying to grow, the cells aren't going to die. So the difference from one person to the next can vary widely. And I think it's very important that we don't get upset about a single reading if it's very high. I got one reading that was undetectable, and then I got a call from the nurse at my doctor's office that 2 weeks later they ran it again, and it was now 6. And the first thing I said, you screwed up on the blood. And the next day they called me back and said, oops, yes, we did. And then I found a new doctor. But, it's important.
So what they like to say in the active surveillance group, at least once, if not 4 times during the meeting, is the trend is your friend. So that's something real good to live with. Somebody has their hand up. John S.
Yeah, I'm just gonna chime in because I went to Nagar too. I'm 7 months out. Basically, no side effects. I went from 3.4 to 1.2 3 months after. I saw Nagar, and my urologist. They told me to come back in 6 months, but my urologist did a PSA last month, and it's down to 0.68. But I'm an Avodart, so you got to double those numbers. But it's still the numbers went going down. So
the other thing you also have to remember, if they do it at a different lab,
yes,
very hard to compare. I know with pregnancy test, if you take the sample and send it to 3 different labs, it can vary more than 100%. So, I mean, they'll still be pregnant. They usually get that right, but the woman wants to follow the trend. And if it's on a weekend, Quest sent it to a different lab to run it, and they used a different machine, you're going to get results you can't rely on.
Gotcha.
So that's
All
why
right.
the friend is your friend. I like that.
Good. So the important thing is not to get all hung up on one test, particularly the first test. So that's good to know.
Absolutely. Absolutely.
And actually, Mark, I've been using my urologist for the PSA, so I haven't been going to Sloan. I've been Dr. Nagar said I could use mine, so they've been consistent with the lab. So yeah, it's been going.
That sounds great. Stuart, did we get to you? Did you have more?
I was just gonna. It's getting late, but I was just gonna do the follow-up report on my 6-month follow-up. I had a chance to see Dr. McClure. It was about 10 days ago. After having had the combination focal and radiation treatments, my PSA is down 85% in 6 months, and which is consistent with what all of the folks in the trial have been seeing, which is a very fast drop in PSA. And they can't explain why it's happening as fast as it is, because neither the focal nor the radiation would normally expect for them to see what they're seeing. So they're a little bit mystified, but very pleased by the results. And then the other really positive news that came back from the trial is that half of the members of the trial have passed their 12-month anniversary and had their confirmatory biopsies. And of the 23 people that have made it past 12 months, they haven't seen any signs of recurrence yet. Which he said that if he had done 23 focals, he would have definitely seen recurrence by now.
Stuart, do you have a sense as to whether they might be willing to offer this approach to other people?
They're starting phase. They're preparing for phase 2 of the trial, which is going to be a 3-way focal only, radiation only combo trial, with the goal of seeing that the combo is no worse than the other two. I wonder whether they're going to have how much luck they will have in filling that trial, because I'm not sure how many people would want a 1/3 chance at focal only. But that's their next step.
Yeah.
Okay, Zali, you're up now.
Hello, everybody. Thank you. I have an update. I'm chasing this high number, PSA number. And I just recently was put on antibiotics for 2 months, and then a small period, and had my latest PSA test. Well, it went even higher, from a 22 to a 27. With, of course, just one single GG2, the other 3 cores are 3+3, nothing in the 2 MRIs, nothing significant. And that's where I'm at.
Remind us on the biopsy, how many cores, and did they do a blind biopsy? And have you had another reading on the slides yet?
I have not had another reading on the slides. My first biopsy, there were 12 cores. 6 of 12 or 3+3, and all like under 20%. The second one, the only thing I have here in front of me is that one was a GG2, the other 3 was GG1. The second perineal biopsy.
Did you send them out for a reread, Zai?
No, I have not done that yet. No.
you got to send them out for a reread and remind us, where did you get treated?
First time was local here in Michigan. Second time it was at U of M.
That's right. That's right. Now I remember. I mean, U of M is really good. Who's the urological oncologist you're seeing there?
It was urologist was Dr. Wood, and now I'm pursuing an appointment with radiation oncologist, which is Robert T. Dess.
Mm-hmm.
And then you had recommended Todd Morgan.
Yeah, well, I'd recommended Todd Morgan as a urologist.
Oh, okay.
Okay, not as he's a urologist. He's not a radiation oncologist.
Okay.
I
just feel I have to move forward with some type of treatment.
It is a toughie. It's really a toughie because with your PSA climbing the way it's climbing, I think you've just moved into a high risk category, if I'm not mistaken. And you could ask them, and they would do it at U of M to have a PSMA test, but something isn't quite right. It doesn't add up, because with just a single core of 3+4, to have it driving your PSA like this is weird, wouldn't you say, Dr. Mark?
Well, that's why they gave him the antibiotics. So that makes sense to try, but the fact that it's still going up, it says
Right.
that's probably not the issue. And, it's not likely that you have a 220 cc prostate. So there's something going on, and it warrants evaluation or treatment. And I agree that, getting the read, getting the genetic testing, and potentially even with that, looking at somatic mutations on it when things don't add up, might be worth doing. So the PSMA, the reread, and the somatic testing, did they do a DECIPHER test on it?
No, I'm not sure what that is.
Okay, well, I would look at DECIPHER, DECIPHER. I think that's something that ought to be done on the 3+4 core. Again, your situation is not straightforward, and it doesn't obviously pinpoint where to go with it. Don't let them push you right into surgery. I think you're too young to jump at surgery, although I think most people are. But
or radiation, for that matter. I mean, we've got to get to the bottom of what's driving this, and they should be able to do that in Ann Arbor. I mean, they've got the smarts and they got the docs there. So, moving you around between a urological oncologist and a radiation oncologist to see which is the best treatment may be the right thing to do in time. But we haven't gotten to the bottom of it, and your original urological oncologist should be doing more. I mean, he should be ordering these tests and trying. Your wife is perfectly welcome to come on the screen. It's probably a lot easier than, because I know she knows more than you do. It's not unusual.
Yes, she's my everything. So should I be moving to another one like Todd Morgan?
You probably cannot if you've already been assigned this doc. It's very, very, very difficult to switch.
Okay.
If you can, I would say yes, go talk to Dr. Morgan because he's so good. If you cannot, then you've got to go sit down, and I wouldn't be talking with a radiation oncologist yet.
Okay, okay.
I would say I want another appointment with you, Doc, because I want to talk to you about what's going on here. I don't want to talk about treatment options. We gotta get to the bottom of what's going on. What
Yeah,
was the percentage?
I have a follow-up scheduled with him.
Okay, well, I would see him before you speak to the radiation. If it were me, I'd talk to the surgeon before I talk to the radiation oncologist again. And you got to get those slides sent out to either Zhu or Epstein. And you definitely need additional testing, and I would start with something like DECIPHER or Polaris or something like that. Probably DECIPHER, but
Polaris. Yeah. My original urologist and this new one, just said, get it out, just get it out. And, I'm hesitant to do that.
It's easier to cut than it is to try and understand what's going on. And at 63 years, again, as we said earlier, you don't want to spend the next 30 years wearing diapers and potentially not having an erection. If that's what you need to do, that's fine. But right now, we don't know that you have, the degree of treatable and how to treat your cancer. And we ought to understand, because this isn't adding up. You had the PSA density of 0.23, which also is not in that, there's a risk that says, yes, you ought to be treated, but it depends on which PSA they're using to calculate that PSA density.
I did do a Polaris or Prolaris on 5/18/24. But also,
and what did that say? So what did the Polaris say then, back then?
Personal risk results was 4.7, 10-year risk is 3.1, 10-year risk of prostate cancer metastasizing is 1.9.
Yeah. So something's changed. We don't know what. I would just say that you really need to sit down with a really solid doc at I'm trying to get the list of all of the docs there. I'm looking for my list of the docs. What did you say? See, here's what doesn't make sense. U of M is really big on active surveillance, and they'll put you in active surveillance in a heartbeat. And for a doctor to say, no, I think you should do surgery, it doesn't add up for the University of Michigan. You're seeing them you're seeing this guy in Ann Arbor, right?
Yes, sir. He said I was an anomaly.
Okay, well, why were you an anomaly? That,
because of that number and like the low Gleason scores. Because of the high number and low Gleason scores. I know Mark had said something about my two MRIs were 1.5 T. Mark recommended get a 3.0. And this doctor says I don't recommend that because he said it's a bad test. I don't know if it's a significantly worse exam, he said. And I have an InterStim for my bladder. But the InterStim people told me that I could get a 3T.
And again, I'm just looking for my list of the list of the doctors here. They don't make it easy for you. They don't make it easy for you. What did you say your guy's name was?
Wood.
Wood.
Andrew Wood.
Okay. We can do a little. Mark, would you mind tomorrow dropping a line to Howard and seeing what he knows about this guy? Because he's
Yeah, I basically picked him out of a hat at U of M. So, in all honesty,
I mean, I think specifically, I don't think much of someone who would say do surgery without having DECIPHER, reread on the path, and diagnosis and understand what the disease is. I mean, you haven't had the PSMA PET scan?
the PET scan.
Yeah.
Yeah, I had a PET scan.
Okay.
not a PSMA. Not just any old PET scan. Was it a PSMA PET scan?
Yeah, it's PSMA PET scan.
You did?
11/8/2024.
Okay, and what did that show?
Asymmetric left greater than the right seminal vessel, PSMA taken mildly enlarged prostate with diffuse and heterogeneous PSMA uptake with bilateral dystrophic calcifications and no convincing scintigraphic evidence of PSMA avid neoplasm.
Okay, so it didn't show anything outside the prostate.
Correct.
So the seminal vesicle that was a different size didn't light up?
It said the left was greater than the right seminal.
Size-wise?
And mildly enlarged. No,
But it didn't say anything about uptake of the PSMA in the gland, in the seminal vesicle.
Says the left greater than right. I'm looking through other documents.
Look, the bottom line is you need more information. You gotta get together with Wood, and you gotta say, I don't know what's going on, and it's got to be more. What was the percentage of 4 in that core?
I have it here. I'm sorry, I got papers everywhere.
6 of 12.
Pardon me?
That's 6 of 12.
A percentage in the core?
Yes.
6 of 12?
4%.
4%.
Yeah, it's a 4% of 4 in that one core isn't going to drive. It's not going to drive your PSA like that. And you've got to talk to Wood, and you've got to say, what the heck's going on? And if he doesn't have an answer for you, you say, well, can we get a GU medical oncologist in there? Ask to see Smith. And let's say he's a medical oncologist, and so he's going to have a broader view. But you've got to challenge him. Have you discussed my case with Dr. Morgan? You got to ask him, show him that you know who the doctors are there, and that you're not happy about being pushed into a treatment of surgery or radiation when all you've got is 4% of 4.
Yeah, one of my why goes there was because they talk about this whole team approach.
Yeah.
That they sit down and discuss every patient with all these different entities.
Well, then that's why they're moving you over to radiation oncology. But
well, that was me, to be honest with you, because I'm like, I got to do something.
Okay, well, I think that you need some other eyes on this, and I would say Dr. Morgan would be. They won't shift you, but you can ask, and what. I'd like to know what Dr. Morgan thinks of this. Does he think I should move into treatment with 4%, 4, and that's it? and you know that you gonna have to push them.
Okay. Okay.
I mean, just like I said to somebody else earlier on, you got to be your own best advocate, but
Right.
it's not adding up, right, Dr. Mark?
No, there's something that we're missing or we don't know. And to take someone into an operating room with a question mark on your belly, we don't do that, or we shouldn't do that.
Gotcha. Okay.
Well, thank you, everybody.
Thank you, guys. Appreciate it.
Wish us luck here in LA. That I think I'm on the other side of the mountain, so I'm gonna be safe here, as long as they don't nationalize the state. We are considering seceding, so I don't know if California pulls out of the country, whether we'll still be welcome in this AnCan community. We certainly hope that's the case. I saw that Jessica left.
Yeah, she'll be back.
Okay.
She'll be back. I have another name for you, Zali. Dr. Palapatu. Palapattu.
Oh, I know the name. Yep.
Okay. So he's like the head, he's like the big chief. And we have a little pool behind the scenes at University of Michigan. I've never had to use it yet, but one of our AnCan supporters for many years, in fact, they just made a very nice DAF donation this week, is a huge booster of the urology group. And if necessary, you know, I can call him and say, something isn't right here. Can you talk to Palapatu? Can we do something for Zali? So let's see how you do. When are you supposed to see Andrew Wood?
It's first week of July.
Yeah, I try and bring this all forward as well. Certainly you need to get your DECIPHER ordered before then, and you need to get those, call them up and have them send out to either Zhu or Epstein before then. But we can definitely help you to try and drive this down. And if you're not happy with Wood, we may be able to help out.
All right. Thank you so much. Thank you.
Okay.
Okay. Well, good night. Well, I guess next month one of the screwy months again.
Yes, we're back. Not next meeting, but next month. July is a screwy month again. Thank you for reminding me. We got to. But let's see. Can we do it without disturbing you? No. I think we've got to move you. We're going to have to move you, but we have 5 dates that we can move you to. So we'll talk about it and see which dates you want. You can pick the dates.
Oh, okay.
No, we don't have 5 dates. What am I talking about? We have 3 dates we can move you to.
Okay.
Because you can't have the 8th and you can't have the...
The 8th is a Tuesday anyway. I have me down for the 14th and the 28th on my calendar.
Wait a minute. 14th and the 28th is not... Oh, I see where we are. No, wait a minute. I'm screwing up here. I think we can leave you right where you are, because the second Monday. No, we've got to. The first Monday is the 7th, so and the second Tuesday. So we've got to move the 8th. All right. This is where I have to. This is why I pay Alexa.
You talk to Alexa and get back with me.
Yeah.
And her get back with and we'll
Yeah,
figure out
yeah,
what to do.
yeah. But we'll try. We'll let you know. Okay.
Sounds great.
Sorry, guys. Housekeeping. Bing, bing, bing.
Everybody be well. Stay
Goodbye,
well.
everybody.
Whenever the next time is, we'll see you then.
Thank you for everything.
Thank you very much.
Good night, everybody.